Welcome everyone to this Independence Age Friday briefing. Those of you who watched last week's briefing will, I'm sure, remember the incredible, powerful testimony of three young people, Hood, Alma and Noah. They spoke about what the year has been like for them and the impact that it's had on their mental health. And this week we're continuing that theme and welcoming a special guest onto our panel. Alan Stein is Professor of Child and Adolescent Psychiatry at Oxford University, and he's going to be talking to us specifically about the impact that the pandemic is having on children and young people, and the best way to talk to them during these uncertain times. So we'll come to that later in our session, but we always start with the latest facts and figures. So here is Dr. Kit Yates with those figures and his analysis. Kit, over to you.
Thanks, Alice. I'll just share my screen and put it in presentation mode, so hopefully you can all see that. So it's a bit of a mixed picture this week. Cases and positivity rates look like they've been declining, but they are showing signs of leveling off in some regions. Hospital admissions have been rising, but are now beginning to plateau, which is good news. Deaths are showing signs of slowing down as well as a consequence of hospitalizations, which have been slowing down. The rate of the first dose of vaccination is increasing, which is also positive news. And so I'm going to be looking at these 5 parts during the presentation today. So cases, hospitalizations and deaths are the usual thing that we look at. I'm going to go a little bit more deeply into death because over the last week we've seen record numbers of reported deaths, and I'm going to sort of try and break down what exactly that means and how deaths now compare to what we were experiencing in the first wave. And then I'll talk briefly about the vaccination data and then compare how this lockdown is to the first lockdown and whether it's more or less stringent and what's happening, and trying to give a bit of data for that. So I should say firstly as well, thanks to Bob Hawkins, who has been helping to prepare lots of the data and the graphs for this presentation. So looking firstly at cases, this is UK cases, daily reported cases in green. The black curve is the 7-day average, and it looks like a very positive picture. It looks like cases have been declining for between 2 and 3 weeks now. But actually, I think these case data present a slightly misleading picture. The ONS infection survey just came out about an hour ago for the first time for a couple of weeks. So we've been trying to assimilate what that says as well. This is a screenshot from their data, which also suggests that cases are falling, but maybe not quite as rapidly as the case data suggests. So this is looking at percentage positivity. So the ONS survey samples a random sample of people and tests them whether they're symptomatic or not. And this has shown a small decline since the last time they reported on this survey. So it looks like positivity rates and cases are falling, but I think cases are appearing to fall more quickly than positivity rates. So let's dive into that in a little bit more detail. So this is the number of new confirmed cases per 100,000 people in the nations of the United Kingdom. So England in red, Scotland in blue, Wales in green, and Northern Ireland in black. And again, this case data looks like things are very positive, coming down in all the nations, most quickly in Northern Ireland, slightly less quickly in Scotland, but it paints a positive picture. And these are tests done by specimen date rather than by reported date. So there's a little bit of a lag usually, which is why the data only go up to about 5 days ago on the 16th of January. So that looks positive. But then what we always like to look at is to adjust for the number of tests that are being done. Because sometimes things can look good because people just aren't going to get tests. So what we look at is the positivity rate. And if you adjust for the number of tests that are being done, you see a slightly different picture. Northern Ireland in black still seems to be coming down quite quickly. Scotland and England less quickly. And actually Wales looks like it's had a sharp decline, but is now potentially plateauing or starting to increase. So it's really important to look at the data by positivity rate as well as just pure cases, because testing rates do make a difference to those figures. So still positive, but we need to be keeping an eye, particularly on Wales, and to make sure that positivity rates don't start to increase across the other home nations. breaking down just one more slide on cases or two more slides on cases, just looking at England, breaking this down by region. Again, the same picture when you look at just cases per 100,000 people in each of these regions. You see most of the regions are declining, potentially apart from the West Midlands in orange there, which seems to be flatlining, but most of them are seeing small declines, most of the regions. But again, when you look at positivity rate data, it's a bit of a different picture. So London doesn't appear now, the yellow curve doesn't appear to be falling quite as quickly as it was in terms of what we saw in the case data. And actually there are a lot more regions in the positivity rate which seem to be flatlining. So the West Midlands, the East Midlands, the Northeast, and Yorkshire and the Humber in purple here. Previously in the previous slide, the case data, I'll just flip back to it, looked like these were all falling quite nicely, but actually they seem to be plateauing or flatlining most recently. So they have seen falls, but it suggests that in those regions R is around 1. We're not managing to get cases to fall quickly anymore if they're falling at all. And that's sort of reflected in the ONS survey, which came out today. It's sort of a mixed picture across different regions. Again, it looks like London is falling, but maybe not falling that quickly. Similarly, with the Northeast, the Northwest seems to be flatlining. Southeast seems to be falling, but again, the West Midlands and Yorkshire and the Humber seem to be plateauing. So it's a very similar picture from the ONS survey, which is always positive when we know that two different data sources are agreeing with each other. And the last bit I want to do on cases is just looking at local. Left of the screen to the right by the prevalence this week, by the positivity rate that's occurring in those local authorities this week, from highest to lowest. And the orange dot is where we are this week, and the grey dot is where we were last week. So when the grey dots are above the orange dots, that's good news. That means positivity rates are falling in those local authorities. But when the orange dots are above the grey dots, that means that positivity rates are increasing. So overall, we're seeing that positivity rates are decreasing in most local authorities in England, but there are maybe around 50 local authorities where case rates are increasing, or positivity rates are increasing. So again, something to keep an eye on. It's a more nuanced and mixed picture than the headline figures would suggest. And I've got these for Scotland and Northern Ireland and Wales as well. I'll just show them briefly. It's the same sort of picture. Most local authorities in Scotland are seeing falls over this week. Similarly, in Wales, most local authorities, with the exception of 2 or 3, are seeing falls. And again, in Northern Ireland, all of the local authorities have seen falls over the last week, which is consistent with what the overall picture was telling us. So that's case data. So effectively, it looks like things are coming down, but if they're still coming down, they're coming down quite slowly. In terms of hospitalizations, this is hospital admissions in England. And what we're seeing here is still extremely high levels of hospital admissions. So it's been above 4,000 hospital admissions a day for the last week or so, or week or two. It is now starting to come down, which is good news. And that is reflected somewhat in the regional admission picture. So this is the 7-day average of the daily numbers of new hospital admissions per million people across the different regions. And again, looking at London, you can see the light blue curve at the top here. There's been a big decline, similarly with the southeast and the east, where cases were highest and hospitalizations were highest. They've come down the sharpest. But actually, if you look at the southwest and the northwest and the Midlands, you're actually seeing these hospital admissions plateauing rather than falling. So going back to the previous slide, this fall is largely being caused by London and the southeast and the east, rather than this being a fall that's happening across all regions of the country. And the other thing to say is that just because hospital admissions are falling, that doesn't mean that occupancy is falling, because actually, if the rate of people leaving the hospital isn't as high as the rate of people coming into hospital, even if that rate of people being admitted is falling, that doesn't mean that occupancy is going to fall. So actually, we're still seeing increases in occupancy in hospitals because the rates of admission are so extremely high. Even though it's good news that they're coming down overall across the country, they're not coming down fast enough. People are not leaving hospital, being discharged as quickly as they're being admitted. So occupancy is still increasing, and you can see that we have significantly higher occupancy now than we ever did in the first wave, well over 50% more than we did in the first wave. So hospitals is a very mixed picture at the moment. Moving on to deaths. So this is deaths by reported date, and this is deaths that you find on the government dashboard within 28 days of a positive COVID test. So this week, you can see at the very right hand extreme of the figure here, we breached the 1800 mark. So we had 1,820 deaths reported on Wednesday, which is, as you can see, the highest number of deaths that were reported across the whole of the pandemic, including the first wave. Now, there are a couple of things that we should say about this. Firstly, because we are looking at these statistics all the time, we somehow get immune to them. So it's always important to remember, I think, that we should, that each one of these statistics is a person who's died from this disease, and that they have a family out there who are mourning from them at the moment. So it's important to remember that. In terms of the caveats, though, with these statistics, yes, this is the highest reported number that we've had over the whole pandemic, but we know that there are fluctuations in this death data. So you can see it in the data, it goes up and down during the week. So earlier in the week on Monday, we had just, and I say just with reservations, because this is still an unacceptably huge number of people dying, but we had just 600 deaths reported. So some of those 800 are lagged, and it doesn't really reflect the average number of people who are dying each week. And it does grab the headlines. And to be fair, this is the figure that we've been using all the way throughout the pandemic to report deaths. So it would be strange to change the way that we're reporting it, but we should be aware that there are nuances behind that. It's the most up-to-date metric we have, but actually perhaps more helpful is looking at deaths by date of death. They're not subject to these reporting fluctuations. And so this is the figure from the COVID dashboard, which shows deaths by date of death. And you can see that, again, this is the figure for within 28 days of a positive COVID test. You can see that we are up above 1,000, averaging maybe 1,100 at the moment for this second wave, which is higher than at any point during the first wave. That we never breached the 1,000 average deaths there. Again, there are caveats to this. That said, their deaths within 28 days of a positive COVID test doesn't mean the same thing now as it did in the first wave. I think everyone knows that we were missing a lot of people, so we're not testing enough people. So cases certainly didn't mean the same thing in the first wave as it did in the second wave, but also we weren't testing as much as we are now. And so there are some deaths in the first wave that were definitely missed, that we're not missing in this second wave. So to some degree, the second wave figure is higher because we're seeing more of these cases and catching them. And so really a more accurate way to look at this still is to look at deaths from death certificates, deaths reported on death certificates or registered. And this is data that the ONS collects. And you can see reflected what I was suggesting there, that in the first wave, this is per week, this data, blue is England and Wales, purple is Scotland, and yellow is Northern Ireland. You can see that actually for the week ending the 17th of April, we recorded nearly 10,000 deaths. And actually, we haven't reached that sort of peak in this second wave yet. This week has been the highest so far at about 6,500. That's without Northern Ireland's deaths because they report a little bit later. But you can see that in terms of death rates, we're not quite at the same position that we were back in the first wave. Again, there's another caveat to say this second wave has been a lot broader than the first wave. So overall, there are far more deaths in this second wave than there have been in this first wave, despite the fact that you could argue that we knew what was coming in the second wave. We saw what was happening in the first wave, and still we've had these unacceptably high numbers of deaths. So that's very depressing and somber news. This is slightly more positive news about vaccinations. So this is just looking at the number of first and second doses that have been delivered across the whole of the United Kingdom. So blue is first doses and yellow is second doses. And you can see that initially we were just giving first doses, as you would expect. And then actually we started to give second doses. And then we changed our strategy to delivering just a single dose, and you can see that those second doses have now dropped off and are really not being delivered. Overall, the rate of vaccination is increasing, which is really good news, because we need to be getting well up above the 2 million a week mark if we're going to be reaching the target of vaccinating all the vulnerable 15 million vulnerable people by the 15th of February. That's the target that the government set themselves. So this is similar data, but this is just for first doses now, and this is broken down by the home nations. So red is England, blue Scotland, green Wales, and black Northern Ireland again. And you can see it is good news. We had a slight dip over Christmas in the numbers of first vaccines delivered, but now this is increasing rapidly. And if this continues to that target of vaccinating the 15 million extremely vulnerable people by the middle of February. And again, this is just one more piece of vaccination data, which is just looking at the number of first doses delivered, excuse me, per 100,000 people for each of the home nations, so that England doesn't completely swamp the figures as it does in this previous figure. And you can see the rates are increasing across all 4 home nations, which again is really positive news. So that's vaccination. The last thing that I want to look at is why we haven't been able to, given that we're in a lockdown, bring cases down as fast as we did in the first lockdown. Part of it is due to the fact that we have a more transmissible variant. But if anything, that would suggest that we should be having at least as stringent a lockdown now as we were having back in March. But the evidence is suggesting that that is not the case. So just looking quickly at schools, attendance in schools is roughly 5 times higher than it was during the first lockdown. So in primary schools, attendance is 21% compared to 4% in the first lockdown. In secondary schools, it's 5% compared to 1% in the first lockdown. And in special educational needs schools, it's 30% compared to 8%. So significantly higher across all educational settings. Those are figures for state schools. This figure, as you can see from this chart, there's been a significant rise in the outbreaks of COVID associated with educational settings since pupils were allowed back into school. Proportionally, it's been smaller than it was before Christmas in special education, in secondary schools, but it's higher than it was in nurseries because we know that nurseries have been allowed to stay open. It's higher than it was, or at least level with where it was in special educational needs schools. So it's suggesting that schools being open is associated with outbreaks of COVID, and especially so because we have far more people who are designated as critical workers now who are allowed to send their children into school and are doing that. Schools are at much higher levels of occupancy than they were in the first lockdown. Just looking at this, so this again is just to say this is the ONS data suggesting that the levels, the positivity rates in children between the age of 2 and year 6, so primary and early years children, is starting to increase again, whereas it's going down in secondary school children, and it's sort of level in college and university age adults. So schools are having an impact again. Looking at workplaces, again, these last 2 bars showing outbreaks of different respiratory illnesses associated with workplaces. So yellow is COVID and grey is no organism reported. And you can see that there's been a big rise since people started going back to work in the new year. So that's workplaces are another place where COVID can spread quite readily. And then 2 other pieces of data. This is retail footfall. So this shows that this has varied over the year since March. So it's relative to levels at March, 1st of March last year. So back then it was at 100%. In the first lockdown, it fell to below 20% at some points, and then it's varied throughout the year. It falls each time we have a lockdown, but this lockdown, you can see it's around 30% of March levels. So it's significantly higher than it was in the first lockdown. And again, we should be careful in interpreting this data, because retail footfall is a proxy for people mixing. It isn't suggesting necessarily that people are mixing, but it's a proxy measure. So we can't infer too much about the mixing, but it suggests that there will be some more mixing. Similarly with mobility data, again, people driving somewhere doesn't necessarily mean that they're going to mix more, but it's a proxy for people's activity and where people are driving to, potentially driving to work, and mixing in those settings. So again, looking at this data, again, it's normalized by levels at the previous year. You can see we had a big dip to around 30, 35, 40% in the first lockdown, and this lockdown we're up above 50% in terms of mobility data at the right hand end of this chart. So you can see that there are big changes in terms of the way people are moving about. In all, it sort of suggests that there are various pieces of data which allow us to conclude that this lockdown is not as stringent as the previous, or at least the first lockdown was. Okay, so that's almost it for me. I'll summarize by saying it's good news that hospital admissions are decreasing, but they're still at extremely high rates. So hospital occupancy is still rising. So we really need to work as hard as we can to get admissions level down if we want to see occupancy levels decreasing. Deaths are still high and rising. They look like they're slowing down and potentially coming to a peak, but again, the more we can do to slow down hospital occupancy, hospitals increasing their admissions, then the better this will be. But it does look like deaths are going to plateau in the next week or so. Good news is that vaccine delivery is improving week on week, so that's incredibly positive news. It looks like we're going to be able to vaccinate a large number of people. Again, the usual caveats that vaccination is not a silver bullet. It's not the whole solution. We still need to be careful about other non-pharmaceutical interventions to keep on top of the spread. It isn't going to solve all our problems, but this is a good piece of news that we are delivering vaccines quite quickly, or at least the first doses of the vaccine. You've seen from the data just now that this lockdown 3.0 isn't as strict as March's lockdown, despite the fact that we have a more transmissible variant to contend with. And that's reflected in the fact that cases look like they're probably still falling, but they're not falling as fast as we would like them to. And so it suggests that R, if it is below 1, is not far from 1. And really, we want to be bringing cases down as quickly as we possibly can to relieve pressure on hospitals as quickly as we possibly can. So that's it from me. I'll hand back to Alice. Thanks.
Thank you very much for that, Kit. We're going to move straight on to questions from the press, starting with Nigel Nelson of the Sunday People. Nigel.
Yeah, in the light of the Israeli study, what is your view of whether the second dose must be given within 21 days? Is there a difference then between the Pfizer, AstraZeneca and Moderna vaccines as to second dose? And what chance of the variant now getting through all three?
Thank you very much, Nigel. And I wonder who would like to start with that. I'm presuming that Deenan might want to. Professor Deenan Pillay.
Thanks, Alice. Thank you, Nigel. A very important set of questions for which we do not know the answer, the answers, and clearly we want to get as much information as possible. Just some comments on the detail. You do mention the Israeli rollout of the Pfizer vaccine, and they are collecting data. And there have been reports in the press, different newspapers around different sorts of data, particularly around fall off of antibodies, potentially increasing susceptibility after one dose, and particularly in the elderly as well. But I must say that until we actually see the detailed data, it's really very difficult to conclude anything, and I would hesitate to comment any further, other than to recommend to those investigators in Israel, who obviously have very important data which could be very useful for the rest of us, to make that available in whatever scientific form as possible, and that shouldn't be a problem. and clearly there's now when it comes to the UK, I would say, and we've said within our independent SAGE documents, that where there is uncertainty, and clearly around dosing, there is uncertainty because there have not been the clinical trials on the Pfizer vaccine, for instance, to look at different dosing schedules, for instance, 3 months rather than 3 weeks. But whilst recognizing the public health emergency we're in, and therefore the need to balance that the breadth of people given the vaccine versus sticking to the original protocol, there is the opportunity to do a whole lot of research here to actually in real time get the data. And we would urge government, Public Health England, National Institute of Health Research to ensure that these studies are being done. I think that's essential for us, because the vaccine rollout will of course take some time, and we need to be guided by the science. With regard to the final question about the variant, again, this variant is more transmissible. I think there is unequivocal data now to show that. And the reason it is more transmissible is that it can probably, or as a component of that increased transmissibility, are mutations that change the structure of the virus, which may make it less susceptible to the antibodies generated by vaccines, or in fact, the antibodies generated by infection with the previous variant of the virus. There's a lot of work going on now. I know that there's a number of studies, clinical studies in process in the UK to look in detail at that, but we should be aware that in the longer term, for what it's worth, my view is that we may be moving to a situation where at regular intervals, maybe yearly intervals, there need to be a fine tuning of the vaccines to take account of new variants that have come in. But I'll finish by saying there's no evidence as of yet that any of this variation, the variants, make the vaccines non-effective. And we would argue very strongly for speeding up the vaccine rollout as it is. Thank you very much.
Thank you very much, Dina. Can I just clarify that when you say speeding up the vaccine rollout, do you mean by increasing the numbers of first doses and holding back on those numbers of second doses, which is what the move from 3 weeks to 3 months implies?
I think that is the case. Having said that, we've also got to recognize why this decision has been taken by MHRA and the Joint Committee on Vaccination and Immunisation to extend the Pfizer dosing to 3 months, and that's to do with vaccine availability. We've got if there was a wide-scale, 24-hour-a-day immunization program that had been planned in advance, ready to go, and there was unlimited supply, clearly we would want to vaccinate according to the protocol. So we've got to also recognize that this compromise is a function of a supply issue, as well as the ability to give vaccines.
Thank you very much indeed. It was an incredibly comprehensive answer. Is there anybody else on the panel who would like to comment on that before we move on to the next question? I'm also really pleased that our very first question of the day has actually answered a question that went unanswered on Question Time last night, which is quite astonishing, with a frontline medic asking exactly that question. So Julianne, who was the frontline medic on BBC Question Time last night, if you're watching, your question has finally been answered. Moving on then to the next question from the press, and it comes from Martin Baggett, the health and science editor for the Daily Mirror. Martin.
Hi, yeah, I just wanted to ask, do you think poor compliance is a significant driver to the current high infection rates? And what do you think is justifying the focus on fines for people attending house parties and the blaming of public compliance?
Thanks very much, Martin. So where does the blame lie with this? Professor Stephen Reicher.
Throughout this pandemic, there's been a fear that the public will be the weak link. So before the first lockdown, we asked would there be behavioural fatigue, and we delayed lockdown, which probably cost tens of thousands of lives. But we found that compliance was very high. Then in the autumn, with the circuit breaker, the second lockdown, again, people said, well, is compliance fraying? And the evidence showed again, it didn't. And now we're having exactly the same types of arguments this third time round. Are the public the problem? And all the evidence suggests that actually compliance is not only high, but figures coming out last week suggested, if anything, it's higher than before in areas where people can practically comply. So with all the things like keeping your distance, wearing a face mask, hygiene, compliance is extremely high indeed. The one area where compliance is low is self-isolation, because that's practically difficult, but that's probably a different question. The evidence suggests that the problem does not lie with the public or with public fallibility. Of course, there are a few people who are breaking the rules. There is a small minority of people breaking the rules. But to concentrate on those while ignoring the fact that the rules not only allow, but sometimes require people to go out and work, to go in and out of each other's houses, is like, in a sense, putting your finger where there's a slight trickle through the dam and ignoring the huge breach that is going on just next to you. So, of course, all of us would say, don't go out and socialize. Don't go out and have a house party. But today there's a front page headline about 400 people attending a wedding. Appalling, but at the same time as 400 people are attending a wedding, probably something like 20 million people are required to go to work. So this is a distraction from the real problem. The problem is not the public. And in areas where the public are not complying, the answer is not to wave your fist at them and to threaten them with fines. It's to support them to self-isolate, to support them to be able to stay at home, to support them to be able to furlough. And that's not happening. And a series of figures came out last week to show that. So first of all, when you look at furlough, 71.5% of working mothers were refused furlough. Right? They want to work at home, they're not allowed to, they're forced to go out and expose themselves and possibly spread the virus as well. So the answer is the public are not the problem. The problem is, in many ways, not that people are flexing the rules, but that the rules are far too flexible. And that's what Kit's data showed very clearly indeed.
Thank you very much, Stephen. And there's a real issue here with fairness as well. Professor Susan Mickey, I can see that you want to comment here as well.
Yes, thank you. If I could just pick up this issue of isolation, because your question was saying, are people not sticking to the rules associated with the problems with transmission? And in relation to not adhering to self-isolation when people have symptoms or when they're contact, the answer is yes. The data suggests that even people with symptoms, only 18% of them isolate for the whole period. And the main reason people go out is they feel they're getting better, the symptoms have gone away. But the second most frequent reason for going out is to go to work. And people are going out because they haven't got enough income in order to stay home. And if you think about how we're going to get out of this pandemic, we've got three main parts of this jigsaw. One is vaccination, one is the test, trace and isolate system, and one is adherence to all the other behaviours that Steve mentioned. And throughout this pandemic, we've all known, and the government's known, that the test, trace and isolate system has been a failure. And if you look at the countries around the world where they've managed to control the pandemic well, they're getting back to life pretty well as normal, their economy has been relatively protected, they have really good test, trace and isolate systems. So the government absolutely needs to, at this point, I think they're beginning to realise that vaccination isn't the magic bullet, just as the app wasn't, just as the moonshot programme wasn't. And they must sort this out. And it does mean a root and branch, radical reform of the whole system and putting it where it belongs, which is in the local public health structure within regions.
Thank you very much, Susan. And Dr. Zbader Hack, you wanted to say something here too.
Well, very quickly, this is an issue about inequality. Most of the people who are not self-isolating are those on low incomes, are those in insecure jobs, are those who are being forced to go out to work rather than be supported at home. So the key issue here is really, have the government supported people on low incomes? And they haven't. You know, we've heard about the £500 isolation support. We've heard about the statutory sick pay and so on. But statutory sick pay, some 2 million people are not eligible. And we know with the self-isolation support, even though the government are talking, even though there's been some rumours about it being extended universally, at the moment, some 70 to 80% of people are being rejected for that £500 support, which incidentally is not enough. But it's the people who are earning the least. It is the most vulnerable people who are the most exposed that are the least likely to get that self-isolation support. And that's why, to a great extent, this pandemic is carrying on and the cases are increasing rapidly.
Thank you very much, everybody. Right, moving on to the next question, which comes from Tom Magner of Carers World. Tom.
Thank you very much indeed, Alice. There's been a great deal of discussion in our audience about vaccine priorities and age bands. The key principle emerging is that unpaid carers, who are a wide range of ages, are asking why can't they automatically receive their vaccines at the same time as the person for whom they care, as their physical and mental health is inextricably linked. The politicians are all ignoring this aspect, so I'd like to ask, how important from an expert point of view is this idea of pairing vaccinations in these circumstances for controlling the pandemic? Thank you.
Thank you very much, Tom, for that important question about carers. Who would like to start with answering this before I start picking on people? Okay, I'm going to pick Kit because he's offered. Kit.
I am by no means an expert in this. I'll just suggest the vaccine priority ordering is largely comes down to mathematical modelling. So people model what would be the most effective way to save the most number of lives or to reduce the years of quality life lost. That's the metric by which they try to minimise. That said, those mathematical models can't take into account every single nuance that people that real life holds, and so actually it's very doubtful whether those models take into account the fact that a lot of extremely critically vulnerable people who need care will be most of the time paired with someone else, and it's unlikely that will have been taken into account in these models. Certainly intuitively it seems incredibly sensible if you're going to be seeing someone who is extremely critically vulnerable a large portion of the time, and you need to go out into the world to do the shopping for them and to do the everyday things that people are doing, that those people get a vaccination. So all I can say is that the modelling suggests a particular priority, but the models don't always take into account every nuance of the real world.
Thank you very much, Kit. I'm going to move on now to our final press question, which I am going to read out. It comes from Ashley Cowburn, who is the political correspondent for The Independent. And he says it would be interesting to hear from scientists on the panel when they think should be the earliest point to end the national lockdown. So when could be the earliest possible end to this lockdown? Professor Gabriel Scally.
Well, I don't have a crystal ball, and I don't think the Prime Minister and the ministers have a crystal ball. And I think this trying to foresee the future with this pandemic is a really dangerous thing to do. It creates, if it's overly optimistic, undue expectation, and may even lead to people preempting what they think is going to happen. And I think if you listen to the data presentation from Kit earlier, you will see just how bad it is now compared to anything we've experienced before during this pandemic. So the situation is atrociously bad. Now, vaccination is going to help. Of that, there is no doubt. But we are going to continue to need substantial social restriction till we get the cases down. So the answer is the restrictions can be lifted when we get the virus under control. And we don't know how long that will take, and we don't know how well the government is going to handle that process. And we have said repeatedly that we need things like a proper find, test, trace, isolate support system. We need controls on our borders to stop new cases coming in. We need a range of measures, including a return to a very well promulgated 2-meter distancing rule. So there's a whole string of things that we need, and it's simply not possible, I think, to forecast when the numbers will be low enough to lift restrictions.
Right, I can see a couple more people who'd like to answer this one. Please keep it short. Professor Martin McKee.
And to amplify what Gabriel said, we need to drive it down and keep it down and be sure that we can continue to keep it down. Because if we are going to continue with the absence of a strategy that we have so far had in this country, nobody can plan ahead, nobody can book summer holidays, nobody can plan weddings. So that is why we've been consistently arguing for the elimination of domestic transmission of this virus, as has been achieved in countries from New Zealand to Uruguay to Finland, keeping the levels very low down in a way that is predictable.
Thank you very much. And Professor Stephen Reischer.
One of my favourite quotes is from the novelist Thomas Pynchon, who says, if you get people asking the wrong questions, you don't need to worry about the answers. And again, I think this is one of the wrong questions, when it will be lifted, because we can't know. The real question is, what can we do to make it as short as possible? And I think the problem is that by talking about the future, the government again distracts attention from the things it should be doing to shorten the lockdown, because nobody likes lockdown. Nobody wants lockdown. Lockdown is loathsome in a whole series of ways. But number one, as we've already said, the best way to have a short lockdown is to have an effective lockdown. An effective lockdown is a shorter lockdown, and we need to make sure we cut down on all the ways in which there's interaction between people. Secondly, we should be making our public spaces, our schools and so on, safer, so that it is possible to open them earlier. And that's simply not being done. We're doing nothing to ensure that our schools are safe, as we've discussed at great length. And thirdly, as has been mentioned, we need to make our test and trace system better, including isolation and supporting people for isolation, so that we can deal with outbreaks quickly and effectively. So the real question is, what is the government doing to make sure those happen? And our concern is that it's not doing enough. Indeed, it doesn't seem to be doing very much at all.
Thank you very much for those responses. I know there were a couple of other people that wanted to respond as well, but I'm going to have to move on, I'm afraid. So I'm going to invite Paul Kenyon, who's a critical care nurse from Liverpool, to ask his question. Paul.
Hello, you okay? So I just wanted to ask, perhaps one of the most overlooked issues throughout the pandemic in relation to retention of staff is mental health of staff that are working on the front line. We're seeing ever increasing levels of anxiety and depression and burnout amongst staff. And that's coupled with obviously the additional pressures that the pandemic's causing for everyone in the general public as well. So I was just wondering if the panel could suggest what sort of preventative measures could be taken right now in order to make sure that staff are available to work on the front line when we need them.
Thank you very much, Paul, for that important question. So looking after mental health for our frontline healthcare workers, who would like to start with that question? Professor Susan Mickey.
Paul, it's an incredibly important question, and I think we should have an invited guest and a session focused on this at some point. And I think the question you're asking for people like yourselves, what can you do right now to try and prevent mental health problems in this incredibly stressful situation you're in? And that's a huge question with many different angles to it. But I would say a couple of the things that's really important. First of all, to think about what things you can control, because there's so many things you're in a situation you just can't control. But what things can you control to make things as easy as possible for yourself? Secondly, just think about support. what support are you getting at work, but also outside of work. And really important to connect with people and to ensure that you ask for support, that you take opportunities to talk through things with people, because we know that that is really helpful. And also, I would say, if people are really struggling, don't hold back from going to GPs and going to services to get extra support right at the moment. And finally, I would say, be compassionate for yourselves. You spend so much of your time being compassionate at so many levels at great cost to yourselves, that just remind yourself that self-compassion is really important. And I think nobody deserves self-compassion more at this point in time than healthcare staff.
Thank you very much, Susan, and thank you, Paul, for that question. We now have a question from Jacqueline Bailey Nelson from London. Jacqueline.
Thanks, Alice, and hello, everyone. My question for the panel is, how would you seek to reassure those of us in the Black, Asian and minority ethnic community who are hesitant about or simply against having the vaccine because of fears that the vaccine may be harmful to us, given that A, the BAME community appears to be particularly susceptible to the virus, and B, the lack of clarity over whether any members of the BAME community took part in the vaccine trials?
Jacqueline, thank you for that question. Dr. Zbader Hack, would you like to start with that?
Yes, Jacqueline, it's a really, really important question, particularly given that we've got more and more data showing that Black and ethnic minority communities, but also incidentally, Eastern European communities, there are quite a few communities out there that are showing signs of what we call vaccine hesitancy, which is very different, of course, from the anti-vaxxers who are just against all vaccines. Now, as you rightly point out, Jacqueline, that a lot of those concerns are quite legitimate concerns. These aren't completely irrational fears. I know there's been conspiracy theories and myths such as, there's gelatin in the vaccine and so on. But a lot of them are to do with the fact that Black and ethnic minority communities in this pandemic have not been protected given the higher risk and exposure to the virus. So I think the answer greatly lies in this government not only acknowledging that, but carrying out a public information and awareness campaign, rolling that out about vaccines, doing a full sort of, frequently answered questions, a thorough Q&A about all the questions, that people have about the vaccines. And I think the government really needs to work with local public health professionals, with faith communities, with outreach community centres, with all those groups to really get to the people who are the most vulnerable. And that is the really key thing here, which is it is the most vulnerable who are likely to have the biggest fears. And we need to reach those communities very quickly.
Thank you.
Thank you very much for the question and that answer, Zbader. I want to get on to our section on mental health and Alan Stein's presentation shortly, but there's a really important question to squeeze in before that. So please keep the question short. It is important, I know. Louise Helps from Southampton. Louise.
So, thank you. My question is in relation to pregnancy, the vaccine. So the BMJ reported that pregnant women are at a higher risk of being admitted to ICU with COVID. And a recent newspaper article also indicated that in the UK this wave has seen an increase in pregnant women in intensive care. So can you confirm if pregnant women are generally at a higher risk in the third trimester? And if so, do you think we should be included in the vaccine rollouts? The guidance states that women should work from home at 28 weeks and keep safe. But there are thousands of women like myself whose husbands and partners work in higher risk jobs. So my husband's a gas engineer and he goes into multiple people's homes a week. And obviously I'm concerned that he might pick it up and bring it home to me. So any advice would be great.
Thank you very much, Louise. Can I come to you, Professor Anthony Costello, for an answer to that?
Louise, that's a really important question. Yes, pregnant women are more vulnerable. Pregnant women are immunosuppressed for very good reason, that they want to avoid rejecting their baby. I mean, it's a foreign body, if you like. And so the natural process is to damp down your whole immune system. And indeed, diseases, if you have a disease like rheumatoid arthritis or tuberculosis, which depends upon the immune response, you actually feel much better during pregnancy and then have a rebound afterwards. There have been two very big studies, one in the whole of Sweden, which showed that pregnant women who were infected with COVID were 6 times more likely than their non-pregnant peers to end up in an ICU, and a very big study done in the United States of 90,000 women of reproductive age that showed that they were 70% more likely to end up on a ventilator, though not more likely to die, presumably because they're younger and fitter and stronger. But just before this call, I was talking to a friend of mine who's an intensive care unit doctor in London, and indeed he had seen a pregnant woman die from COVID. So this is a serious issue. And on the immunization front, I think the trials of the 3 vaccines did not enroll pregnant women or children. I believe that trials are now ongoing to look at the impact of the vaccine. Initially, the government said we shouldn't vaccinate children and pregnant women. I believe that that was changed by the chief medical officer to make it a clinical decision. And my view would be that beyond the first trimester, obviously you want to avoid any so-called teratogenic effects, of deformities in the first 12 weeks. But later on, if you've got a lot of underlying risk factors, let's say you've got diabetes or gestational diabetes or obesity or hypertension, there is an argument actually for vaccinating. And I think that should be a clinical decision. But you've raised an incredibly important point. I'm not sure I've answered your question fully, but pregnant women are more vulnerable. They should be fine. I mean, we're talking about very, very few women that will die of the condition, but I think the decision about vaccination is a very open one.
Thank you.
Thank you very much for the question, Louise, and thank you for that, Anthony. And now it's time to go to our special guest, Professor Alan Stein, for a short presentation, which will be followed by a few more questions. Alan.
Just having a bit of difficulty sharing my screen. Can you hear me?
Yes, we can. Yeah. We can hear you, we can see you, but we can't see your slides at the moment.
Sorry. Yeah, okay.
Do you need the slides?
Yeah, there they go.
Lovely. Okay. Well done.
Okay. Great. Just go back. Good. Well, thanks very much. And thank you very much for inviting me. The information and the data provided to us by Kit at the very beginning was stark and very important. But this sort of information about enormous number of deaths, and as he pointed out, everyone is one person and their family, and all the people know them, and all the new infections every month and every day have enormous impact and dominate our discussions on media, social media, and the mainstream. And together with that, there are lots of public health messages about staying at home, keeping safe. And all of this creates an enormous amount of anxiety and stress, and just the tone of discussions we've been having here this afternoon about our concerns and worry, and we're all adults. This has an enormous impact on children. And on top of it, children's entire lives are changed. Their routine has changed, their social infrastructure is gone, they don't have access to friends, all these things which help maintain one's own mental health during difficulties. And you're stuck at home with your families. Children are actually very astute observers of what's going on around them. Even very young children under the age of 3 are aware of changes due to COVID. They understand and aware of changes just generally around them. They're very good at picking up on changes in facial expression and in emotions on the people around them. And then the other aspects of the development occurs slowly over time in the early years of life. Their understanding of illness, their understanding of separation, their understanding of death. But all these things occur, and they probably occur a lot earlier than many of us think. So what happens is we're very good at telling children the facts about the pandemic and all the things that relate to it, but we're not so good about talking to them about the emotions and what this feels like. And what children are in effect doing is they try to put together a coherent picture of all these things, all these changes that occurred in their lives, all this information from the media, and trying to work out what's going on. So the important thing is that we communicate with them, and we communicate with them about, and we talk to them. All parents would do anything to protect their children from distress, but not talking to them, not telling them really isn't helpful. And it's unfortunately always left in this case to parents and carers to actually do this. But we do know that sensitive and effective communication has enormous benefits for children in terms of their long-term health. There are many components to effective communication. Of course, the one thing is to tailor information to children's age and understanding. The other thing is to be what we call emotionally authentic. So children see that we're upset. They see we're distressed. They see we're concerned. So to acknowledge our own concerns, not that we're falling apart, but our own distress and our own concerns, and giving those emotions labels really is a very good way of opening those conversations and helping and share with children. They can begin to share with us what their worries are about. They may not all come out at once, but it takes time. At the same time, it's important, especially with younger children, to use very simple language, not to be patronizing. But I know we all do it, but when we're stressed, we try not to use the exact words, we use euphemisms, and especially when talking about death, that can lead to a lot of misunderstanding. What does passed away mean? What does having lost somebody mean? I think we need to be very clear about what we're talking about. At the same time, we also need to encourage children to maintain routines, to do things which are positive, and to keep their mental health going and do practical things and cope. And we need to support them and to know they're going to be together. But these are kind of some of the simple things that need to be done in these conversations. Perhaps prophetically, a few years ago, the Lancet commissioned myself and a few other people to put together a series of how we communicate the diagnosis of life-threatening illness to children. And it actually came out just a year before the pandemic started, almost to the year. And what we did, we put together all the evidence, and together with this set of platforms and structures as to how you actually do this and how you actually communicate to children and to families about life-threatening illness. And in fact, that's been very helpful to us going forward, specifically when talking about death. And I'd just like to say just a few words about how we actually talk to children who have actually lost somebody. And although 92,000 people already have died, 2 million people worldwide, this is an enormous number of children affected. One person dying might have children, grandchildren, friends, relatives. So a lot of children are affected. Even one's neighbor dies. These are things that are important. But the big difference to what we did before is that we're in a different world, as we said, and as that mental health nurse quite rightly said, patients are alone in hospital without visitors. Healthcare professionals have few opportunities to develop relations with relatives, and children in many ways are invisible. There's so much going on, and where are the children in all of this? And sensitive news is now often having to be conveyed by telephone in very difficult circumstances, and that leaves the families to share this news with children, with often a lack of privacy and time to prepare. So I won't go into any detail, but just simply say we've put together a set of resources which is freely available on our website, which really give you both a short video and a whole lot of infographics, which guide you very simply through the stages in which we can use to talk to children, just step by step, preparing yourself, finding the words, preparing yourself for important questions, and finding ways to which carrying this on and helping yourself to talk to other adults before perhaps you talk to children. But the important things again is that children will see you getting distressed and you in difficulty. So know what's going on, and sharing it with them is important. So one set of resources actually specifically for healthcare professionals, and we actually have a lot of those translated into several languages. And then there's specific support for families about how to help families to share the news with their children step by step. And it is important to reach out. And in many ways, the heroes of all this are parents. We're leaving parents and caregivers to manage this incredibly difficult task. Thank you very much.
Thank you so much for that, Alan, for those really important thoughts about conversing with children during this difficult time, and for that resource as well. So I hope that anyone who's watching might look at that resource and share it with anybody you think might find it useful. We've got time for a couple of questions now. The first one comes from Isaac Deaton. Isaac.
Hi, thank you. I'm a first-year undergraduate at the University of Manchester, and I was wondering, what should universities, or indeed the government, be doing to ensure that we don't see repeats of situations like students being barricaded in with fences? And what can the universities do to help students who feel isolated and anxious? And should we, as students, be advised on how to support friends who are bereaved or suffering from mental health issues?
Thank you very much for that question, Isaac. Who would like to start answering this? Anthony?
I'm sure my other colleagues can speak more knowledgeably, but I've argued for a long time that, you know, there are unacceptable numbers of people that make suicide attempts or commit suicide in universities. And I felt for a long time that you should have group meetings. And if you're in a pandemic, this kind of meeting with, you know, a dozen people on a corridor in a block or a hostel or, you know, wherever, and that everyone should be invited to join. And it could be facilitated by a third year or something who's able to do that, so that you can all talk and share your experiences, because it is therapeutic and will help you to identify some people who may be struggling, who are not willing to talk about what's going on in their lives, and they're more likely to talk to their peers. So I think peer groups formally constituted by universities should be something that should be done both during this pandemic, perhaps online, and afterwards in space. But I'm sure others will have other advice about counselling.
Thank you so much, Anthony. Alan, would you like to comment here?
Just to add, yes. I mean, first is to support Anthony's point. I think, you know, groups and support groups are incredibly important, and not to make them too big, I think, but small groups of supporters are very important. I think obviously universities are trying hard, but they do need to plan ahead. I think there's some sudden changes the last couple of months, which have actually been very difficult for students, and many students are being left at home in very difficult circumstances to write exams. For some kids, that's actually okay. It's manageable because they have good circumstances. Others are really difficult and facing. And so I think there are good counselling services, and there are actually quite a lot of services, not just within universities, which are now available for people, which people can use, and I think they should use them. So I think all those things are important.
Thank you very much. Susan, you'd like to comment too?
Yeah, just quickly, I mean, one thing to remember is universities are workplaces, like schools, like any other workplace. And one of the things I think really important to ensure that before people come back to campuses, those workplaces are safe for everybody to come back to, so people can feel reassured, and so there won't be further outbreaks. So I think one thing is to use your collective voice to ensure that things like good ventilation have been installed where needed, and to ensure that other procedures are put into the university, working with our health and safety officers, so that you can come back with reassurance to safe campuses.
Thank you very much, Susan. I've got a question that's come in via Twitter, and it's anonymous, but it's an important question. So I'd like to read this one out. The question is, my husband and I are both key workers, and our 8-year-old son has been going to school throughout the lockdown. He's become very anxious about the idea of bringing COVID home and infecting me or his dad and making us ill or worse. He's showing signs of OCD, for example, washing his hands and getting very upset if he comes home to find we've moved anything. What can we say to him to reassure him when the news is telling us that we should be worried about sending our children to school? I wonder if that's something that you could talk to, Alan.
Yeah, I mean, it's not easy because in a way, your little boy is reflecting something that's real. But I think my view is that once you've made a decision, and you've obviously had to make a decision to send him to school, I think the important point is to make it clear exactly what you are doing to help him and to support him through all of this, and to allow him to open up these conversations. I think you're obviously doing a lot. It sounds like the school's doing everything they can. I think to make it clear and show him everything that you are doing. And I think sometimes also giving him another form of communication like drawing or writing, but drawing especially can be a nice way of doing it. It isn't an easy situation, but I think if it got any worse, there are some very good self-help. I don't think getting into Candace's point is very easy, but there's some good self-help guides around helping children with anxiety. And I would look at those because they actually are very good in kind of guiding this. But the problem is, in a way, you've got realistic anxieties here to deal with. There's no simple solution, but I think you've made a decision, and I think I would do your best to reassure as best you can and provide other ways of expressing these concerns.
Thank you, Alan. Susan.
Sorry, coming in because I was a child psychologist for many years. But I think what you say about your son being anxious if things aren't exactly where they were previously shows that he is really looking for control over his environment in a situation where he and all of us have got very little control. So I think one of the things quite specifically is to show him, demonstrate, support him, to allow him to think about what he has got control over and give him experiences where he can see for himself he's got control over things. So that's just, I would add to what Alan said with that specific suggestion.
Thank you very much for those answers. I'm going to squeeze in one last question, which Gail in Colchester asks, I'm concerned about the negative impacts that large amounts of screen time are having on younger children. My 11-year-old daughter spends 5 hours each day online for homeschool. Then in the evening, her dance classes and all socializing is carried out on WhatsApp or Zoom. Other than the obvious things like going outside each day for exercise, what can we be doing to safeguard our children's mental health? And do you take this into consideration when recommending tougher restrictions and lockdowns? So that's a complex question about the amount of screen time and how that plays into mental health, but also about how we balance tougher restrictions. Alan, can you answer part of that on the mental health side?
I mean, again, we're just in very difficult realities. There are very few options for parents. I think you shouldn't be too hard on yourself. I think, if your child is managing okay in other ways and doesn't seem to be having a major impact on them, it's very difficult. What options do they have? So I think I would not lose too much sleep over it. It's hopefully not going to be forever. Find other things if you can, the kinds of things that you might have in your environment, reading, even things like books, audible books and books, really helpful. They may prefer that rather than actually listening to things rather than looking at screens all the time. But you have a limited number of options, and I think you're doing what you can. I just wouldn't lose too much sleep over it.
Thank you so much for that, Alan, and thank you to all of our questioners today, and to our panel for all of the responses. As usual, I would like to invite Sir David King to summarise at the end of today's briefing. Sir David.
Thank you very much, Alice. Once again, not quite a summary, but a few general comments I would like to make. First of all, I want to stress that this problem is not going to be resolved simply by relying on vaccines. We really need to look at behavior. We need to look at the question of isolation of those who have the disease and have been in touch with them. All of these issues remain critically important at this point in time. What I also want to just once again say is that we have not, throughout this pandemic, seen a clear strategy published by the government. And so it is simply quite interesting, to say the least, to welcome the Biden and Harris document already published in their first week of the presidency and the vice presidency of the United States, a 100-page strategy on dealing with the COVID-19 pandemic in the United States. It just seems to me that perhaps our government could pick that up and look through it and imitate not the detail, but the fact of having a strategy. Thank you.
Thank you very much for that, Sir David. Thank you to all of our questioners again, to our special guest, Professor Alan Stein, and thank you to the whole expert panel of Independent Sage. They're all volunteers here who believe that open dialogue between scientists and the public is crucial, especially during a pandemic. All of the reports about Independent Sage are available on the website, along with details of the whole team. There are specific reports focusing on general strategy, schools, vaccination, and many other topics. And we know that unions, councils, and politicians and many, many individuals are finding those reports useful. So do take a look. And please do follow Independent Sage on Twitter if you don't already. We'll be back same time, same place next Friday. Stay home if you can. Stay safe. Keep well. Thank you, everyone.
Thank you. Bye-bye.
Bye-bye.